Chris, I'm sure he can introduce himself, but Chris was one of my trainers for FUSIC HD. He's fantastic at echo, and he's got extensive experience as an echo educator. You can find lots of videos of him on YouTube teaching on different echo things, and an Nepean YouTube channel. He's written books on echo, and he's a good go-to guy. So thank you so much, Chris, for agreeing to teach this session for everybody. I'll hand over to you.
No problem. Thanks. Can you see my screen? Perfect. Okay. So yeah, thanks. My name's Chris. I am an IT reg in London. I've done plenty of echo before. I will caveat everything with saying I have not done FUSIC HD. It was not a thing when I started to do my echo training, but I've clearly had a bit of an echo journey, and been through the difficulties of trying to teach yourself stuff and find the right resources. So I completely understand, and I'm very keen to try and help people as much as possible. And so the first talk is really is the stroke volume abnormal? So it's taking a bit of a turn from what Samson's talked about already, and just trying to be really specific. So this should be a relatively short session. It's quite a straightforward technique, but as with any measurement, it's really important that you do it right, because otherwise it's a worthless bit of information. So hopefully I'm going to try to show you how to do it, and then also some pearls and pitfalls for this, so that we're getting the right measurement. So what I'm going to talk about, we're going to talk about how we actually do this measurement. The pearls and pitfalls have a bit of a discussion as to why bother. We've got lots of other ways and means of measuring cardiac output, but I guess just my 2 pence about why I think it's worthwhile, and I'll really just try and use some cases to emphasize that. What I'm not going to do is teach you, because it's impossible in a 15-20 minute talk, how to achieve the basic views. If you're going to do any sort of advanced measure, then a prerequisite is to be able to do the basic views first, for which everything is built upon. So I'm not going to talk through that again. What I'm also not going to do is discuss Doppler at length, because Doppler is probably a topic that needs a talk itself. It would take quite a while to discuss, and it's probably quite a tedious thing to discuss on a Tuesday evening when everyone's kind of going about their lives. So I'm not going to talk about that. There will inevitably be a little bit about optimization and talking about how we can get our measurement right using spectral Doppler. But I would definitely recommend you consider reading and learning about the differences between different types of spectral Doppler, particularly pulse wave and continuous wave. And you really need to know about concepts like Nyquist limit, aliasing, pulse repetition frequency, because otherwise you can get into a bit of trouble and get lost. So we will give you a link to some resources that you can further look at this, but it's probably not the time to talk about this right now. And I'm also not going to talk about fluid assessment, because that's question 2. So we're going to be very specific and talk just about stroke volume assessment. But clearly this is a bit of a prerequisite to then doing some fluid assessments. So getting this right will make life a lot easier in the future. So before we delve into this might give some people some nightmares, but it's really easy to get stuck in the weeds with echo, particularly using Doppler, worrying about alignment and your views and dynamic assessments, et cetera, et cetera. But before we go into this, just remember that you are already experienced clinicians first. You've got a clear understanding of concepts like mean systemic filling pressure and stressed versus unstressed volume. You're used to dynamically assessing the cardiovascular system. And you may have even had the pleasure of drawing some of these things at the Royal College. And what we're trying to do is layer echo on top of all of this experience, and hopefully add a degree of precision, a method of measuring accurately these things when you are more resource limited, such as in ED, or in the far-flung corner of a geriatric ward somewhere in the hospital. Really none of it replaces the basic clinical assessment. So that's kind of a bit of a caveat before we move on from there. I mentioned there's things that I'm not going to talk about. There are some great resources out there. These are 2 sets of resources with some QR codes by some of my mentors who've taught me tons over the years, and I'm forever grateful for. So there's some really good resources, particularly things like YouTube are just phenomenal. And half of what I learned was from YouTube, and probably the other half is from these people. So there's some QR codes to that. There's also a QR code here for this is specifically a video from POCUS 101, who do lots of quite short videos, but this is specifically doing a stroke volume assessment using either a Venue or the slightly smaller machine. So it's probably worth having a little look at this. I think the measurements are not completely perfect, but it gets the point across that you can then finesse. So let's start with how, because this is really probably what people want to know from this, rather than me rabbiting on about resources. So the key method that we're going to use for measuring stroke volume is this. And it's a 2-step process. The first step is going to be measuring your LVOT diameter from a parasternal long axis view. And this is just a caliper measure that we'll talk a little bit more about shortly. And the second step is to measure what's called the stroke distance, or the otherwise known as the velocity time integral, or VTI, that you may have heard people talk about. And this is looking at the bulk forward flow of blood through your LVOT, taken from an apical 5-chamber view. You can also take it from an apical 3-chamber view. Sometimes the alignment is a bit better, but you're going to measure basically the area under the curve of all the velocities of blood moving forwards through this LVOT. And then it's going to be multiplied by the LVOT area that is calculated from the LVOT diameter. So this is a measure that we're going to do to measure stroke volume that can obviously then be turned into cardiac output, cardiac index, etc. So starting with the LVOT diameter, so we're going to take this from the parasternal long axis view. This is a familiar, should be a familiar view to all of you. I have just put the anatomy on there, but hopefully you all know already. Just remember that in intensive care, it can be quite difficult with people having hyperinflated, mandatory ventilated lungs. Often the parasternal long is a much lower down the chest and therefore is much more angulated. So we're going to find this view, and this is your home when you're starting off doing your scanning. And then the step that we need to take is to zoom into that LVOT and then make sure that we're happy with our view, freeze it, move back and forth until the valves open and you're in mid-systole. And then you're going to place specifically the LVOT diameter measurement at the insertion point of the aortic valve leaflets, or just proximal to that. And then you're going to measure inner edge to inner edge, and it's going to give you a diameter. Now, if you use the LVOT diameter measure itself, then it will automatically calculate the area for you. And that's really important, which for a reason that we'll come on to later, and it stops you having to do it all yourself. So I'll just go through that again quickly. So we're going to zoom into the LVOT. We're going to freeze it, zoom back and scroll back and forth until the valve is open. And then at the insertion points of the leaflet, we're going to start our measurement, and we're going to use the LVOT diameter measurement from inner edge to inner edge. Now, some key things here, it's normally going to be around 1.8 to 2.2 centimeters. If it's very different to this, then you are probably getting it wrong, frankly. And we all get it wrong. I mean, imaging intensive care patients is really bloody difficult. And the key thing is to look at the number and think, is this right? Is this what I expect? Do you get a 2.5 centimeter LVOT diameter in a 45 kilo old patient? Well, probably not. So just think about the measurements you're doing. From from the LVOT diameter measurement to get the area, it requires pi r squared because it's assumed to be a cylindrical structure that you've done a diameter measurement of. The easiest way to do this yourself is just to do 0.785 times the diameter squared. But because you're squaring the result and it's a small measure, there's a risk that you're going to amplify any errors that you make and get vastly incorrect readings. Okay, so moving on, we'll talk about a few pearls and pitfalls about that shortly. But next, we're going to talk about the stroke distance measurement. And the classic view that we get for this is the apical 5-chamber view. So the apical 5-chamber view is achieved from getting the apical 4 and then tilting the tail of the probe down to get a more shallow imaging angle, and it opens up this LV outflow tract and aortic valve. And then, as you can see, I've narrowed in this sector width. It's nice just to put a bit of color on sometimes to make sure you know what direction the flow is going. But you're going to place the pulse wave Doppler button, place the cursor, I'll just go back slightly, place the cursor just proximal to the aortic valve leaflet, really at the same point that you measured the LVOT diameter. And then you're going to get a spectral Doppler trace. Now you can see I just increased this baseline so that our area of interest was the forward flow. I'm messing around with the sweep speed here, so the sweep speed will show you how many forward flow signals you have in your spectral Doppler trace. And then I'm going to take the LVOT VTI measurement and I'm going to trace it all the way around this signal. And I'm going to take one that looks about right, looks the nicest. Normally we're going to do this in end expiration. That's just standardized for most measurements, but that will depend on what you're trying to achieve. Okay, so just to show you what I've done here, I've taken the LVOT VTI measurement and I've started it at the baseline and I've traced all the way around what's meant to be the modal velocity. So it's maybe slightly overdone here. There's a bit of black there. I'm trying to be very precise and trace all the way around and then get back to the baseline. And then the GE machines, after you press go, will also give you another cursor that goes to the next complex. And because I've already done the LVOT diameter, it's given me the VTI. So this is the velocity time integral. So this is also known as the stroke distance, and that's 15. And it's in centimeters because it's a distance. But because I've already done the LVOT diameter in this case, it has already calculated my stroke volume, which is there at 48 mils. And because we've got this extra cursor, it's pulled in the heart rate. And so it's given me automatically my cardiac output. So the LVOT VTI is normally somewhere between, we say 18 and 22. Obviously, that can be extremely variable depending on whether the patient has impaired function or the fluid's going the wrong way, or they're hyperdynamic and it might be much higher. So once again, just make sure, just kind of stop check that value and think about it in the context of the patient that you've already assessed, you know them clinically, and think whether it makes sense. So I'll just go through that again. So apical 5-chamber view, we're going to get the pulse wave Doppler cursor and place the cursor, this little cursor, at the same point that we've done the LVOT diameter measurement, just proximal to the valve. And the way that we know that we're in the right spot with the cursor is that you get no opening click, but you do get a closing click. So we can see the forward flow here. There's no opening click, but there is a closing click of that aortic valve. If you're too far into the valve, like I was probably on this complex here, you're starting to see a bit of an opening click. So you don't want this. You want to optimize your cursor so that you're going to get no opening click and a closing click. And there you know that you're going to be pretty much in the right spot for where you did the LVOT measurement. Now, that's not always the case. Things like in aortic stenosis, it might be a bit trickier, but for the most part, this is good. Okay, so whilst you can do it in the LVOT LVOT, the LVOT measurement, you can actually also use the RVOT measurement. So this is a short axis basal view that I've just brought around a little bit to show the RV outflow tract, the pulmonary valve and the main pulmonary artery, and the right and the left pulmonary arteries there. So again, same kind of process. You can zoom in. I must say this isn't really something that people do that often, measuring the RVOT diameter. The measurement's often quite tricky to do. But again, you're going to do it just proximal to the leaflet insertion point and then measure that RVOT diameter. You can see that this is a bit bigger. The RVOT is bigger than the LVOT. And then you can do the same thing, place your pulse wave Doppler cursor just proximal to the valve, and then optimize your trace. And once again, get no opening click, get a closing click, and then I'll hopefully turn the gain down a bit. Yep. And then once again, you can trace all the way around it and get an RVOT VTI. Now you can do the stroke volume from this. I wouldn't normally recommend it because the measurement of the RVOT diameter is usually not very accurate, and it's better not to bother. But what you can do is use the RVOT VTI alone as a trend of the cardiac output. There is less evidence for this compared with LVOT VTI, but it is something that you can do, particularly in patients where the apical 5 or 3 chamber view is really challenging to get. So this can be a backup. And the other time that I've used this quite a bit is in people who have either had left ventricular assist devices, like HeartMate 3s or similar, or if they've been on VA, because you can't really measure the cardiac output very well from the left side if they've got a volume loaded left heart, or if they've got continuous outflow from a pump. So you can actually use this RVOT trace to trend interventions in this population, but that's somewhat niche. Okay, and the other backup view is if you get a subcostal short axis view. This is maybe something that you might want to try. So you get a typical subcostal view. You rotate the probe counterclockwise by 90 degrees, and you can get a subcostal short axis view. And so you can see the liver here, you can see the aortic valve here, the right atrium here, tricuspid valve, and the RV outflow tract and pulmonary valve. And then this is, again, the main pulmonary artery. So this often has pretty good alignment. And if you've got no parasternal views, no apical views, you can still sometimes trend the cardiac output from this, which can be quite helpful. Are there any questions about how to measure stroke volume before we go into the pearls and pitfalls?
There was just one question from Takwa, hopefully I said your name right, that asks about whether you measure at the RVOT1 or RVOT2 for the RVOT VTI.
Yeah, good question. So when you're measuring flow dynamics, you have to measure both the diameter, well, the area of the thing that the blood is moving through and the blood flow at the exact same point. Otherwise, it's not a valid reading. So you would be doing it at quote RVOT2 because RVOT1 is your proximal RVOT. So you do it just prior to the insertion point of the valve leaflets, as you would in the LVOT. Okay, so pearls and pitfalls. So bear with me with this. It does get a little bit technical, but I'll go through it quite quickly. So we've already talked about the LVOT diameter being a potential source of error because the error can be squared. We need to minimize this error by zooming in and by making sure we're making really, really accurate measurements. So we're going to do it inner edge to inner edge, just proximal to the leaflet insertion point. We're going to do it in mid-systole. So again, you can use the ECG, which of course you've all attached at 3 in the morning to make sure that you're in the right spot. And then you want to make sure it's parallel and adjacent to the leaflet tip insertion or at the sites of the VTI measurement. So I don't want to go into this in too much detail, but in people with stenotic disease, you can get flow convergence, and that can lead to very high readings for the VTI and lots of artifact. So you often, and also people with prosthetic valves, you often just need to take that cursor a little bit more proximally and then do the measurement at the same point that you're doing the VTI. but I won't go and dwell on that for too much longer. This is an example of a trace that I've done, a spectral Doppler trace, and just highlighting that we've got a baseline, a scale, and a sweep speed. And these are the things that we need to modify and gain also, but gain's not as obvious to see. So the baseline, we want to move up and down to make sure that we're getting the blood flow that we want to see. So we don't want to see this blood flow going upwards. We want to see the blood flow going downwards. We want to change the sweep speed so that we've got only about 2 or 3 complexes in there so that we get good measurements. And we want to change the scale so that we're filling up our Doppler screen. So this is an example of changes to sweep speed. So you may want to do this one on the left if you are looking for LVOT outflow variation or stroke volume variation, but it's clearly not very accurate if we want to do a very small measurement here. And it's much better if you speed up the sweep speed so that you have fewer complexes in your view, and then your measurement is going to be much more accurate. You probably don't need to go overboard and only have 1 in your measurement because you'll be tracing all day, but it's usually recommended that you have 3 in there. So we want to shift the baseline just to measure the forward flow. Make sure you've got around 3 cardiac cycles. You want to adjust those parameters that I've just talked about so that you fill your image with the Doppler trace. And then lastly, you really want to address the gain, because this area here shouldn't have any flow. So it should be black. And what you don't want to see is a grainy image that has Doppler signal in there, because that just means that you're getting artifact. If you have artifact in this part, it means that you've got artifact in this part. And how that manifests is you get much fuzzier signal. It looks a lot bigger, and you're going to get an artificially greater stroke volume. This is an example of an overgained image. You can see that here. You can see that you've got grainy signal here that shouldn't be there. This means that this is much too bright, and this will have a lot more fuzz around it. And you can see that this measurement, there's lots of black inside here, which means that you've overdone it. So this gives you a VTI of 22.1, and it sounds really pedantic. I really accept that. But despite the fact that we found the close and click, which is a good thing, you know, you've worked to get a good signal. You have found it in the right spot with a close and click, and you don't want to ruin it by overgaining an image. So it's overgained, it's poorly traced, and it's going to overestimate the VTI. So laboring the point, but this is taken from the exact same patient. And you can see that we've turned the gain right down. This is black. You've got a hollow pulse wave Doppler trace, which is what it should look like. We've still got close and click. We've traced that modal velocity of, I mean, this is probably slightly undercooked. You probably would want to come down to here. But you can see that there's no area of black in here. So this is comparing 22.1 to 17.7, which is clearly a significant difference and can potentially make a difference to your overall communication of their cardiac output. So we've reduced the gain, traced the modal velocity, and we've shaved the beard, which is what one of my old mentors told me. Okay, so one caveat with this is that if the patient's in AF, then you've got traces that are all over the place. And unfortunately, it's recommended that you should trace 5 to 10 cycles in AF to get an accurate stroke volume. Sorry about that, but that's just how it is. This looks like a horrible slide. And forgetting all of this, people talk about this cosine rubbish, but the key thing is that Doppler is angle dependent. And you can imagine this, we don't always have alignment like this. You know, this is a perfect alignment for a Doppler trace. But if the LV outflow tract is over here and it's going off in this direction, then we're not going to get a good signal. And this is just showing that the more the angle is off, the worse the percentage error is. And the echo machine assumes that the angle is 0. There's no angle compensation in echo. So what the convention says is that an angle must be ideally less than 20 degrees for an accurate measurement. So don't even bother trying to trace it if it's clearly going to be completely wrong. Okay, so lastly, why bother? And this will just be another 5 minutes or so. before, so that I don't bore everyone to death. But I guess, sorry, my mother's calling me. So I guess why bother? We have cardiac output monitoring devices. I love a PA catheter, love a PICO. They're great devices, and they all have a place. And for the most part, we can see when someone's LV is not working. We can see when there's if someone has good systolic function. And when there's all these caveats that I've already talked about, what's the point? We're still clinically assessing the patient, dynamically assessing things. And I guess I want to just emphasize with a couple of these cases that you can get fairly similar readings with cardiac output monitoring. You can get fairly, you can get caught out with just a visual eyeball assessment of LV function. And I don't want to go on for too long about ejection fraction because it's probably one of the least useful things that we have in intensive care. And I could talk about that for way too long, which is slightly sad. But just some of these cases will be quite helpful to emphasize why contextualizing systolic function or ejection fraction with stroke volume is extremely important in our patient population. So ejection fraction does not equal cardiac output. And we know that in formal echo reports, all anyone frankly gives a shit about is ejection fraction. That's all people want to know. And it's the first thing that people say. It's the only thing that's written when someone does a focus study, like a cardiologist does a focus study. And this is fine in the cardiology population. Cardiology have really good mortality data for ejection fraction, for thresholds for starting specific therapies, but we don't have that. And we know that a visual assessment is unreliable in our patient population in a critical care setting. Ejection fraction is load dependent. It's very dynamic. It really changes. It can change within 10, 20 minutes, depending on the interventions that we do, whether that's giving inotropy, giving vasopressors and giving fluids, whether that's changing ventilation strategies, giving sedation and dropping the afterload. And all these things are all going to dynamically change your ejection fraction in the critical care. And that's because EF is actually just a marker of ventricular arterial coupling. And all of those things are dynamically assessed, dynamically changed by the interventions that we do. So if we have someone with a good ejection fraction or too good ejection fraction, then we still need to be contextualizing that with cardiac output measurements, be that with a cardiac output device, a PICO or a PA catheter or whatever your device of choice is, or we can just do it with echo. And that's far more feasible if you're in ED, if you're on the road somewhere, if you're in a far-flung ward in the hospital. If it's going to take a long time for you to be able to get cardiac output monitoring in a patient that you want to that's hemodynamically unstable, and it really doesn't take very long to do it with this. I guess worth mentioning already that doing symptoms biplane, which is what you can see here, well, this is just one of the views, it will give you a stroke volume, an estimated stroke volume here. Now that's great, provided we know where that blood's going. If we know that that blood's all going forwards and backwards, forwards not backwards or sideways, I suppose, then that's great. That is probably relatively accurate, but we just don't know that unless we assess them in a bit more detail. Similarly, in our population, it's pretty difficult to get accurate symptoms biplane. So it's probably not going to be the most accurate thing in the world anyway. So using Doppler is probably going to be a much better way of doing it. I think most people all know this already, but this is a patient with dilated cardiomyopathy. They have a horrible looking heart, but this patient could be walking around the street. They've got a small ejection fraction, but it's a small fraction of a very big volume, 400 mils volume. So actually, their stroke volume is completely normal, even though they've got a low ejection fraction. And they may be fine. And they may be warm and well perfused with a normal lactate, so you don't need to worry about it. Likewise, you've got this patient who has a cracking ejection fraction. It could be quoted as as even hyperdynamic. They could say, oh, this is 65% ejection fraction, wonderful. But it's 65% of not a very big volume. So you can have a good ejection fraction with a low stroke volume. And it's important for us because actually what we care about is getting enough blood out to perfuse the organs and oxygenate everything. So we care more about stroke volume than we do about ejection fraction. I'll stop bittering on about ejection fraction now. So this is a patient who was clearly very hyperdynamic. You know, you could do a point and shoot and look at this and say, oh, this is great. The heart's working well, they're hyperdynamic. Let's just throw on some noradrenaline, get some of that unstressed volume and improve the afterload and they'll be fine. But the patient was cold, they were shocked. And actually the stroke volume was all going sideways. And this is someone who had ruptured their interventricular septum. And it actually got VSD. So their ejection fraction was great, but none of it was going forwards. It was all going through the septum. So they were in cardiogenic shock, even though their LV looked like it was contracting well. This is another patient. This is a 58-year-old who had an MI. He was intubated. He'd been to the cath lab. He was on about 0.3 of NORADs, 0.1 of adrenaline. He was cold. He was shut down. He was on tons of oxygen. And the cardiologist, I actually was with him in cath lab. The cardiologist looked at his heart, said, oh, it looks great. His function's good. We've stented the culprit lesion. Happy days. They said probably at the time he had moderately impaired LV or mildly impaired LV, but they were pretty happy. But actually clinically, this patient wasn't getting better. He still had pulmonary edema coming out of his tube an hour after having a PEEP of 14, which didn't really make sense to us. This heart did not fit with his clinical picture, which was one of cardiogenic shock that was worsening. You know, he had a super high lactate as well. And this was the only view that we could get. We could only get a subcostal view, and it probably wasn't enough. It wasn't until we put a TOE probe in that we saw that actually this patient had ruptured the papillary muscle after his MI that really wasn't very easy to see on the subcostal view and had torrential MR. So all of this blood was going backwards. So again, contextualizing what your visual estimation is with stroke volume is very helpful because it gives you more information and it can point you in the right direction when you think things are not quite right. This is a patient I went to see probably about 4 or 5 years ago now, but this is a lady who'd had a laparotomy for a small bowel obstruction. She had a history of hypertensive heart disease, diastolic dysfunction. You can see a super chunky left ventricle there. And so had an appropriate fluid restrictive strategy intraoperatively. But it was 2 a.m, like it always is. It's always 2 a.m. you're called for the deteriorating patient. And there'd been a rapid escalation in NORAD requirement. There was a low cardiac index on the pulse contour analysis flow track, and the patient was developing pulmonary edema on an X-ray. And the question was, look, this patient's cold. Are they getting a septic like a stress cardiomyopathy or something after an acute insult? Should we start some dobutamine? And for all intents and purposes, this looked like someone with a bad heart. But actually, what this patient had was posterior MR because they had LV outflow tract obstruction, they had systolic anterior motion of the mitral valve, and they were dragging their mitral valve up to this chunky septum, giving them a really high outflow gradient. So it would have been an absolute disaster to give this patient dobutamine. And what they actually ended up needing was just a bit more filling and everything resolved itself. And so again, this is a win for taking the readings that you're getting from the conventional measures and using echo to have a 2D assessment, and then look at what the 2D is with the other numbers that you have and seeing that this is actually something that needs a completely different management strategy. Again, similar thing. I don't need to tell anyone what this is. This is a patient with tamponade, but they were an inter-hospital transfer to a specialist ITU for shock, dyspnea, not intubated, by the way, low cardiac index and a lactate of 7. And this was a cardiogenic shock referral. And obviously this patient doesn't need inotropy, doesn't need fluids, although that could be a temporizing measure. What they need is for someone to put a needle into their heart. And I sort of put this video in just because it's a good video of showing pericardiocentesis, which I hadn't really seen before. So this is a wire going in here, and then drain going in, and then a bit of agitated saline contrast just to make sure that it's in the right spot coming in now. And then after some fluids come off is the next video. Okay. Okay, so, and this is the last case I'll talk about, and then I'll just see whether anyone's got any questions. So I guess the aim of talking about this case is to emphasize somewhat lateral thinking in terms of how you get your measurements, where you get the measurements from, and using echo as a trend. So this was an 80-year-old in septic shock, had reduced level of consciousness, and was intubated in ED. On day 3, I mean, he'd been on around 0.2-ish of NORAD, having the usual workup for septic shock on 40-ish% oxygen, but everything was sort of gradually getting better or seemingly at least stable. But on day 3, he developed cool peripheries, his noradrenaline requirement went up to 0.6. And really the question was, what next? And if I show you these pictures, it's quite clear that, I mean, this looks like a horrible heart. It's barely contracting. It fits with our clinical suggestion that he was in cardiogenic shock that had flourished from his septic shock. All we could get was a subcostal view. He was on tons of PEEP and was quite unstable, wasn't rolling him and stuff. So we could get a subcostal view. So this is a subcostal short axis view. It looks like a parasternal, but here's the liver. So again, subcostal view, turning the probe 90 degrees counterclockwise, and then we have a short axis, which is quite nice. Well, the view is nice, the pictures are not. But what we could then do is tilt up and get the RV outflow tract that I showed you earlier. And what we could do is trace the RVOT VTI that is normally a bit lower than the LVOT VTI. So we say the LVOT normally around 18 to 22, give or take a bit. The RVOT VTI often around 16-ish as a ballpark figure. So a little bit lower, but still should be in the teens. And here it was 7.6. So clearly this is not great. So the patient's in the low cardiac output state. There was an attempt to put a PICO in, didn't work. The patient had very calcified vessels. And so we were using echo as a trend. In result of this, we started some inotropy. So we started milrinone because it was raised PA pressure and it was a choice of the intensivist. But we were then able to use echo to trend our results after that. So day 4, so this is the next day, we can see that the contractility already looks quite good. The patient's clearly got some myocardial recruitability with the inotropy that we've given. He was only on 0.2 mics of milrinone, but he had renal failure too, so we didn't want to go too hard, too fast. But his NORAD requirement had come down. His lactate had gone from 5 to 2. And then once again, still just with a subcostal view, his RVOT VTI had gone up to 12.8. So again, just using the simple measures that we had, this is 24 hours later, things have gradually been improving, and we can demonstrate that we've changed things by the intervention that we've done. And then day 5, his milrinone had started to be weaned down. His NORAD was off. His lactate was normal. And the LV started to look a bit better. His PEEP had come down. We were suddenly able to get some apical views. Horrible looking mitral valve calcification. But his LV looks a bit better. And again, we've got this subcostal short axis. This view shows it much more nicely because his windows were a bit better. And now we had what was essentially a normal RVOT VTI. So this is just showing that in situations where we don't have cardiac output monitoring, where we suspect a clinical change, we can still be using echo and measuring things like stroke volume or not stroke volume, using VTI as just a trend to dynamically assess the impact of our interventions and hopefully demonstrate improvement or not. So I guess the summary from this is it's actually quite an easy technique to layer into your advanced skill set, with the caveats that you have to do it precisely, and please do consider the pitfalls. This is a single element to an advanced scan, and there's lots of other technique that will need to go into it as you're learning. But overall, this is quite a quick and easy technique that you can use at the bedside, wherever you are, to get an idea of someone's cardiac output. We really, in our population, need to be contextualizing that visual estimation of systolic function with stroke volume, because we're not doing full studies, or not necessarily doing full studies with Fusic HD, and we may want to, maybe we do want to do a brief assessment of valve function or look for pulmonary hypertension, things like that, but we can all get caught out. All of us do. All of us miss that, apical muscular VSD that we miss because the windows were rubbish, the endocardial definition was rubbish, and we just assumed that the patient's systolic function was good. But if the stroke volume's low and the systolic function looks okay, we need to explain that. So we need to go back and look at it in a little bit more detail, or ask someone who maybe knows better. Echo can give you an important structural, it gives you important structural data and hemodynamic data above what cardiac output monitoring can give you. But I don't want to be there echoing a patient every hour. So using it in combination with our conventional cardiac output monitoring, or comparing how accurate our uncalibrated flow track cardiac output like pulse contour analysis is really helpful. And lastly, the LVOT can be a good backup for stroke volume trending, a slightly more evidence-free area, but using it is a backup, but has different values. And lastly, just make sure that when you've done an intervention, you go back and have another look, just to make sure that what you're doing is right, you haven't made things worse. And we're going to be doing this anyway clinically, but most units have tons of ultrasound machines now, and it doesn't take a long time just to double check the same measurement that you've done before to see if it's changing. So thanks very much. I hope that was useful. And if anyone wants to WhatsApp me or email me, I mean, I'll be quicker at WhatsApping, but then feel free, and I'm happy to help anyone with anything.